Hello, everyone. Thank you for joining today. We're just going to give everyone else a second to trickle in before we get started. All right, so we're going to jump straight into our Navigating Your IVF Journey webinar. Today, our host is one of our wonderful fertility specialists, Dr. Susan Maxwell. Dr. Susan Maxwell is one of our newest physicians here at SCRC, and she is leading our Santa Barbara location. She has had experience tackling complex fertility issues and always ensures that her patients receive the best care possible. A few of Dr. Maxwell's credentials include that she's board certified in obstetrics, gynecology, reproductive endocrinology, and infertility. She completed her residency and fellowship at New York University School of Medicine, and she has had extensive training and experience at top fertility programs in New York City prior to joining SCRC. If you would like to learn more about Dr. Maxwell or connect with her, please check out her Instagram using her handle at Susan Maxwell MD. Now I'll hand over our webinar to Dr. Maxwell.
Thank you. Well, I'm happy to be joining SCRC, which has a proven track record with more than 25 years of experience. We have state-of-the-art embryology laboratories in both Los Angeles and Santa Barbara, with on-site surgery centers. And we have 3 locations in total in Beverly Hills, Pasadena, and Santa Barbara. Next. Why do we have a premier ART labs? Well, a lot of it has to do with the technologies that we've invested in those laboratories. We have experienced and certified laboratory directors, double witnessing verification, which is really important, so that you can feel ensured that your gametes are in safe hands. We practice vitrification, which is a freezing method, which has been shown to improve the viability of frozen eggs and embryos. And we do a lot of blastocyst biopsy, pre-implantation testing for aneuploidy, as well as for monogenic disorders. So we can test all 24 chromosomes within the embryo and do sex selection. And we'll talk more about why that's important. And then we also have embryoscopes in both our laboratories, both in Los Angeles and Santa Barbara. And the embryoscope is a technology which allows us to watch the real-time development of embryos in the laboratory and see if they're progressing normally or if there are abnormalities present. Next slide. Today, I'll talk a little bit about why patients experience infertility and the age factor. We'll go through what testing is performed for the fertility workup, our holistic approach, and then the IVF cycle process and transfer in detail. And then I'll answer questions at the end. So infertility is defined in patients under 35 years old as those who have been trying to conceive for 1 year. And in patients over 35 years old, if they've been trying to conceive for 6 months. And the reason for that is the chance of conception declines with age. Next slide. So to give you an example, in women who are under 25 years old, their chance of conception per month is about 25%. And this is relatively stable until age 30. And then we start to see declines in natural conception rates. So by age 35 or 36, the chance of natural conception per month may be about 10 to 15%. And then it drops down below that for women in their 40s. The reason for this is that genetically normal eggs go down as women get older. So in a 30-year-old, the percentage of normal embryos is about 50%. However, at 40, that may be about 20%, and it drops down to 10% in the upper 40s. Next slide. So one difficulty that women have is, unlike men, they're born with all of the eggs that they'll ever have in their ovaries. And the number of eggs in the ovaries peaks really before birth. Women will have about up to 7 million germ cells. But the numbers decline rapidly. So by puberty, there are under 1 million eggs present in the ovaries. And every cycle, when a woman has her period, she loses hundreds of eggs. So by the time she goes into menopause, which is approximately age 50, there are no eggs remaining in the ovaries. Next slide. So as part of the infertility evaluation, we take a detailed medical history and we do a physical exam and diagnostic testing. Part of that testing is looking at ovarian reserve, or trying to determine the number of eggs remaining in the ovaries. And there's a few different ways that we do this. One is through blood tests, such as checking different hormone levels. The anti-Müllerian hormone is a test that looks at the total pool of eggs in the ovaries. It's not an absolute number, but it's a relative number. So the AMH is a hormone that's secreted by the small follicles on the ovaries. So the more small follicles a person has, the higher their AMH levels will be. And the level of AMH does have to do with someone's age, because as women get older, the number of eggs do decline in the ovaries. The other hormone tests are an estradiol and an FSH hormone. The FSH hormone is secreted from the brain, and it stimulates the ovaries to produce an egg each month, and from the ovary also estrogen. So as the FSH levels go up, that is telling us that the body is having a harder time releasing an egg from the ovaries because the total egg pool has declined. The third test that we do is a pelvic ultrasound. And when we look at the ovaries, we are looking for those small resting eggs. And here you can see a picture of an ovary, and the little black circles inside are antral follicles. And each one of those antral follicles should contain an egg. So when we do the ultrasound, we're looking at how many of those we see. And it's normal to see somewhere between 5 and 10 on each ovary. Next slide. On the male side of fertility, we recommend doing a semen analysis. And when we look at the semen analysis, we're looking to see if the volume of the sample is normal, if there's a normal number of sperm, and the motility of the sperm is important, because only moving sperm are viable. And then we also look at the shape of the sperm as part of the semen analysis. However, the shape of the sperm tends to be less reliable when it comes to the impact of that on fertility. Overall, the concentration and motility are the two most important factors. Studies indicate that 25% of infertility is primarily male factor, whereas 40 to 60% of infertility is affected by sperm. So here at SCRC, we believe in a holistic approach to fertility, and that involves overall wellness and taking care of yourself. Components of that are nutrition plays a huge factor, reducing stress, either through methods such as meditation, exercise, or things like acupuncture may be beneficial. There are many benefits of nutrition for fertility. Vitamins and nutrients are linked to positive effects. Healthy diets such as the Mediterranean diet may be beneficial. Eating plant-based foods such as whole grains, vegetables, legumes, fruits, nuts, and seeds. I think when you think about diet, the most important factor is whole foods and avoiding processed foods. Processed foods have a lot of added sugars and fats and salts and things that don't provide any added nutrition, but are high in calories. And so as much as you can shift away from processed foods and move towards foods that you have to prepare yourself, such as those plant-based foods and those whole grains, vegetables, and fruits are beneficial. Folic acid is one of the most important supplements early on in pregnancy, and it's necessary for correct formation of the fetal spine. And folic acid can be found in legumes, asparagus, and dark leafy greens. And also we recommend that you supplement folic acid in your diet. Vitamin B12 is an important vitamin. It's present in organ meats, clams, sardines, beef, and tuna, and omega-3 fatty acids, which can be found in salmon, cod liver oil, sardines, chia, and flax seeds. Next slide. Going into a little bit more detail on different supplements for fertility, we recommend that you take a prenatal vitamin, and it's good to start your prenatal vitamin a few months before you're ready to conceive in order to have adequate levels of folate and vitamin B12. Those are associated with improved fertility, live birth rates in IVF, and lower ovulatory infertility. Folic acid, the recommendation is to have at least 800 micrograms of folic acid per day. So check your prenatal vitamin, make sure that you have an adequate amount. If your prenatal contains less than 800 micrograms, I recommend taking a supplement on top of it. CoQ10 is another supplement that has been shown to be beneficial for women with infertility, and it is a strong or potent antioxidant. It is associated with increased number of eggs retrieved, higher fertilization rates, and more high-quality embryos. And really, the data shows that all antioxidants are beneficial for fertility. So even if you're supplementing with eating a lot of berries or acai, those are also beneficial. Vitamin D is an important supplement. Women who with normal vitamin D levels have 4 times higher IVF pregnancy rates compared to deficient women. And some studies have shown that deficiencies in vitamin D are also higher among women with miscarriage. So the recommendation is to take at least 1,000 units of vitamin D per day if you are deficient. Next slide. It's important to avoid toxins when you're trying to conceive. Toxins include alcohol, cannabis, and tobacco. Having more than 4 alcoholic drinks per week during IVF is associated with lower live birth rates and a higher risk of failed fertilization and lower number of eggs retrieved. There was a recent study that showed that women who drank excessively at the time of ovulation had significantly lower pregnancy rates that month as well. Cannabis should be avoided. In IVF patients, cannabis is associated with fewer eggs retrieved and lower percent fertilized. Cannabis also has a strong effect on sperm. So if your partner has had a semen analysis with low counts and motility, it may be beneficial for him to avoid toxins and repeat that analysis in 3 months. Tobacco has been shown to reduce AMH and antral follicle counts, reduce IVF success rates, and increased pregnancy loss. Tobacco also needs to be avoided in pregnancy because it can cause small infants or lower birth weight infants. Next slide. This slide just talks about the different rates of conception with different fertility treatments. So in a natural cycle, as we reviewed previously, those pregnancy rates can be somewhere between 5 and 20% per month. And then in women who are infertile, it's less. It's between 5 and 10% chances of pregnancy per month. When you add clomiphene, or ovulation induction agents such as Clomid or letrozole with IUI, those pregnancy rates in women with unexplained infertility are still only about 10% per month. Injectable gonadotropins with insemination have pregnancy rates of about 12 to 15% per month, but they're much higher risk of having multiple pregnancies. And then in vitro fertilization really has the best success rates to achieve pregnancy. And we'll talk about that. Okay. Next slide. This slide goes over the process of IVF. One reason IVF is more successful is with IVF, we give stronger injections to cause multiple eggs to develop at one time on the ovaries. In general, our goal is to get somewhere between 10 and 20 eggs to develop, but it really depends on a woman's underlying characteristics, how many eggs do develop with the gonadotropin injections. When you take the injections, we start them sometimes with a period, or sometimes a birth control pill is given first and then stopped, and then the injections are initiated. Injections are given subcutaneously every day for 10 to 12 days. And during that period of time, women need to come into the office every few days for blood work and ultrasounds in order to monitor how they're responding and adjust the medication dosage as necessary. Approximately 2 weeks into the treatment, the follicles will be the appropriate size so that we can retrieve eggs. And the retrievals are done under anesthesia, so you don't feel anything. And we use a vaginal ultrasound with a needle attached to retrieve those eggs. After the eggs are retrieved, they are then fertilized, and then we culture embryos for 5 to 6 days in the laboratory before they are typically frozen for later use. The procedure itself takes about 20 minutes. And then afterwards, the patient goes to the recovery room for about an hour, and then you're able to go home the same day. Next slide. So this is a diagram of what happens during the retrieval procedure. So again, anesthesia is given, so you don't feel anything. And we use a vaginal ultrasound with a needle attached, and the needle goes through the vaginal wall directly into the ovary. And you can see the ultrasound images here of how at the beginning of the process, the ovaries are small with small follicles. Then as the injections are given, those follicles enlarge and the ovary enlarges. And when they've reached the appropriate size, a trigger shot or injection is given to mature those eggs, and then the procedure is performed. The needle easily goes into those larger follicles, and we aspirate the fluid inside. The fluid then contains the eggs, which are passed to the laboratory and then processed. Next slide. So there are 2 different ways to fertilize eggs. One way is to put the sperm in with the eggs overnight and let them fertilize naturally. And the other technique that we employ is called intracytoplasmic sperm injection. And this technique is beneficial, especially for couples who have low sperm counts or abnormalities on the semen analysis. And this is one way to improve fertilization rates. So here we're going to show a video of the ICSI procedure. And essentially a needle is used to inject one moving sperm directly into the egg. So a healthy looking moving sperm is selected by the embryologist and then directly placed into the egg for fertilization. Okay, next slide. Once the eggs have been fertilized, they are then placed into the embryoscope for time-lapse imaging. And so here's an example of an embryo going through different stages of development. So each cell division can be monitored. And then as more cells are developed, you'll notice this embryo becomes what's called a blastocyst, where it has two cell layers, an outer cell layer and an inner cell layer. So in more detail, the stages of embryo development, once an egg is fertilized the next day, we'll see successful fertilization, and then that embryo will start dividing the cells inside. So it goes from 2 cells to 4 cells to 8 cells, which is called a cleavage stage embryo, and then 16 cells, and then it becomes a morula, and then the embryo, when it's has about 50 to 100 cells, will develop these 2 cell layers, where the outer cell layer forms the placenta and the inner cell layer forms the fetus in the future. It's at this stage, the day 5 or 6 stage, where we can perform an embryo biopsy, which is a procedure where we sample a few cells from the outside of the embryo. And that biopsy then is sent for genetic testing. We can test for chromosomes of the embryo, or we can test for single gene disorders if we were prepared for that and they've been identified ahead of time. The advantage of doing the embryo biopsies and the testing is that, as we discussed previously, as egg quality goes down, that means more of the embryos are genetically abnormal as a woman gets older. And so by doing the testing of the embryos and the biopsies, we're able to identify which embryos are genetically healthy. And those embryos give us the greatest pregnancy or success rates when we transfer them. So when we test an embryo and we know it's chromosomally normal, and we transfer that embryo to the uterus, we get success rates of 65 to 75%. Next slide. Once the embryos have been created with the IVF processed and frozen, then we prepare for the frozen embryo transfer. And first, we may do a test called a saline ultrasound, where we look at the uterus and make sure that the inside cavity is normal for implantation. And then we prepare the uterus for the transfer. And this may involve taking estrogen hormones for a few weeks, followed by progesterone to make the lining favorable. At that time, the embryo is then thawed, and we put a thin catheter with the embryo in it into the uterus to deposit the embryo. After the embryo transfer has occurred, a pregnancy test is performed approximately 10 days later. Next slide. So here is an example of our success rates at SCRC, and our rates in general are higher than the national average, and this has a lot to do with our embryology laboratory and the technologies we employ, such as pre-implantation genetic testing and the use of the embryoscope. Next slide. For a list of our current promotions, I encourage you to visit our website, and you can look for promotions in your area and see what they are currently. And I'm happy to work with wonderful physicians here at SCRC. We have the founders of the practice, Dr. Mark Surrey and Dr. Hal Danzer. We have Dr. Carolyn Alexander in Beverly Hills, and myself in Santa Barbara. So now I'll open it up to questions, and we'll do a Q&A here for about 25 minutes. Okay, so I have a question here. Is Omnitrope recommended to improve egg quality? If so, when should it be taken? So this is a good question. This is Omnitrope, for those of you who don't know, is a growth hormone injection. And there is some data that Omnitrope may be beneficial for egg quality, especially in older women, I would say those who are over 40 or who have lower reserve. I think one of the more difficult things about the recommendation is omnitrope is more expensive medication to use. And it would be helpful if there were more studies looking at it in particular with women who are doing the genetic testing, the pre-implantation genetic testing. So I'm hopeful that more studies can be done on it in the future, but it is something that you could discuss with your physician to see whether it may be helpful for you in egg quality. Is there an AMH cutoff for IVF? If so, what is it where it's not recommended? So there is not necessarily an age cutoff, an AMH cutoff for IVF. AMH predicts how many eggs we will get with the IVF process, but it does not predict the egg quality, which is overall the most important factor when determining if you're going to do IVF. I tend to use the FSH, the follicle stimulating hormone, as a better predictor or cutoff for IVF. Women whose AMH is above 14 or 15 tend to not respond very well to the gonadotropin injections. And in order for IVF to be successful, we would like to have 3 or more eggs develop with those injections. So if the FSH is too elevated, that is a sign that potentially less than 3 eggs would be achieved with IVF, and it may not be as successful. Mm-hmm. So this question says, what can be said to someone who says that genetic testing of embryos isn't worth it for someone who doesn't get a lot of embryos, since some embryos can self-correct and good embryo might get discarded? So there's a lot of different opinions on the use of pre-implantation genetic testing. It's important to understand that it is a screening test. So it's not a diagnostic test. It is fairly accurate, but we are only sampling 5 cells from the outside of the embryo. It is the most beneficial for women who are older, but who have a lot of embryos for testing. And the reason is that it can be very difficult to pick the best embryo for transfer without doing the testing for chromosomes. And so I've seen women who are 38 who make 8 embryos, and if they don't do the testing, they're going through multiple embryo transfers that are unsuccessful because we don't know which embryo is the genetically healthy embryo. So definitely for somebody like that, I would strongly suggest doing the genetic testing. If you're somebody who's only making 1 or 2 embryos, there is also a benefit to doing the genetic testing because it can prevent you from having a miscarriage. And when your reserve is low, the last thing you want is to be having a miscarriage and then needing to wait 3 or 4 months till that miscarriage resolves before you can go into another IVF cycle. So for that reason, it may also be recommended to do the genetic testing even if you don't make a lot of embryos. So I think this is sometimes a personal decision and something that you should discuss further with your physician to see if it's beneficial for you. Mm-hmm. How much CoQ10 should women take? The recommendation is to take about 200 milligrams twice a day. So it comes in either 100 or 200 milligram tablets, but I would take it twice a day. Mm-hmm. How do physicians determine which protocols to use? This really has to do with your ovarian reserve characteristics. So we use those tests such as the AMH, the FSH, and the ultrasound to determine what protocol is best for you. And we're really trying, with those protocols, we're trying to get a good number of eggs to develop, and we're trying to get them to grow at the same rate so that we have better maturity rates at the end. So it's really individualized. If it all goes well, can your egg retrieval be one cycle and the implantation be in the next cycle? So it's a 2-month process. Yes, potentially that can happen. Some limitations to that is sometimes we have to get insurance approval for the transfer after doing the IVF, and there can be a delay in getting that insurance approval. Other times, so usually we get the results for the genetic testing within 7 to 14 days. But if there was a delay in those PGT results, it might take us a little bit longer to get into the transfer process. But theoretically, it could be a 2-month. Should men also take CoQ10? Yes, antioxidants are also good for sperm quality. So I do recommend that partners also take the CoQ10. What is the rate of live pregnancy of someone who does PGTA testing versus not at age 36 and healthy? The chances of pregnancy with a single embryo transfer at any age are approximately the chance of having a genetically healthy embryo at that age. So at 36, about 40% of embryos are genetically healthy. So without the PGT testing, the chances of pregnancy are probably 30 to 40% versus with the testing, it would be, 50 to 70%. So here I have somebody asking about fertility preservation and planning, if they want multiple children after age 36. And that is definitely something to consider. We see a lot of women who have their first child and then have difficulty conceiving their second child. So I think if you're thinking that you want a large family and you want 2 or more children after age 35, then it's generally a good idea to be thinking about creating embryos with IVF and saving them for the future. So someone's asking if they have healthy ovarian reserve at 40 and are considering getting pregnant, what are the risks to consider with IVF or IUI? So, the risks of natural pregnancy at 40 are really conceiving and having a miscarriage. Miscarriage rates at 40 can be 20 to 30% chance of miscarriage with a natural conception. If someone's reserve is healthy, it's difficult to go through a miscarriage. It can take some time to recover from that, but there is still time then to seek out fertility treatments such as IVF if needed. But it's really the time factor involved. Generally, we do recommend trying to conceive for 6 months at 40 before starting, more fertility treatments such as IVF. This question is, what are the reasons that embryos are tested and come back abnormal? Is there anything other than staying healthy that a person can do to have better embryo testing results? So we ultimately don't know what causes why egg quality declines and why embryos are genetically abnormal. There are some theories that the longer the eggs are in a woman's body, they may be subjected to free radicals or environmental factors that decline their quality over time. It could also be that these eggs are have undergone multiple divisions in the past and have shorter telomeres or something that's contributing to these abnormalities. And so because we don't know the underlying mechanism for this, it's hard for us to recommend any treatment for someone who is making abnormal embryos. And so, you know, having a healthy diet, taking antioxidants is really the only thing we know of right now to improve egg quality. Mm-hmm. So here's a question of where do sperm donors come from and what is the process for screening them? So most patients who are using sperm donors get them from one of the sperm banks. And these sperm banks recruit donors and then they are screened. They have a medical screening, a physical exam, they undergo blood testing called FDA testing, which is infectious disease testing that's sent to a government approved laboratory to make sure they are clear from HIV, hepatitis, syphilis, and all infectious diseases. They have a psychological screen and a genetic screening test. The donors are tested for genetic conditions that they could pass on to a child as part of that testing. So they do undergo rigorous screening, but it is how they're recruited to donate is these people are just interested in donating in general. Mm-hmm. So for the first consultation, what kind of testing results do you need to have? You don't need any prior testing in order to have a consultation. We will talk with you and order all of the necessary fertility testing at that time. Mm-hmm. Are you able to pick the sex of a fetus? The sex of the embryos is information that is available to you when you do the pre-implantation genetic testing, because we're looking at all the chromosomes, including the X and Y chromosomes. So if you do want that information, we are able to provide that on the embryos. Mm-hmm. So this question is about a hysterosalpingogram. A hysterosalpingogram is a diagnostic test that is done to assess if the fallopian tubes are open. It's typically done in a radiology department, and a catheter is put in the uterus, and a contrast agent is injected into the uterus, and it goes out the fallopian tubes, and they take an X-ray to image that. Sometimes if there is a sort of a small blockage, the flushing of the tubes with that contrast agent can have somewhat of an immediate benefit. We do see some people getting pregnant naturally the next month after an HSG, but we don't know exactly what the chances of that are after having that procedure. But the purpose of that test is more so to diagnose if there's a tubal issue than to flush out the tubes. Mm-hmm. How long after a failed frozen embryo transfer can another one be done? If the result of the frozen embryo transfer is not pregnant, then another frozen transfer can be initiated with that following month with the period. If you do get pregnant from the transfer, then that pregnancy must resolve. And then sometimes you need other testing done by your physician before you can go into another transfer cycle. How much FSH and LH is typically taken during an IVF cycle? So there's two different types of gonadotropins that are given. One is FSH called either gonal-F or follistim. The other is a combination of FSH and LH called Menopur. And some physicians only give the FSH, some give both a combination of the FSH, the gonal-F or follistim, and the Menopur. The typical dose range really depends on a woman's ovarian reserve and ranges from probably 225 total units up to 600 units per day. Mm-hmm. This question says, do you accept new patients from other states who are moving to California, and how are gametes shipped across states? So yes, we do accept new patients who are moving to the state. If you have sperm, eggs, or embryos that are in another state, we can potentially ship them. It really depends on us reviewing the records of where they are. We want to make sure they're coming from a reputable lab with reputable documentation. And our lab director would have to review those records and approve the transfer in of those gametes. So it's really on a case-by-case basis. After a successful pregnancy, at how many weeks do you graduate from the fertility clinic typically? So we want to be sure to document that we have a viable pregnancy in the uterus and that it has a strong heartbeat. And there's no complications. So we typically see a heartbeat develop between 6 and 7 weeks of pregnancy. And then we usually want to see you a few more times before you graduate. I typically tell my patients to try to schedule an appointment with their OBGYN, the first appointment between 8 and 10 weeks of pregnancy. And the reason for that is at 10 weeks, the OB will offer you a screening blood test to again check the chromosomes of the pregnancy and make sure everything is developing normally. How many cycles of IUI do you suggest before IVF? So it's, in general, we recommend an initial treatment of 3 cycles of IUI. After 3 cycles, we then reassess and see if you would benefit from doing another 3 cycles, or if we would recommend going to IVF at that point. After 6 cycles of IUI, we do not recommend continuing with IUI. So the limit is usually about 6 cycles of IUI. However, after 3 cycles of IUI, sometimes we go to IVF or we do more, depending on the characteristics of the individual. Do we work with women who have endometriosis? And at age 49, is donor eggs the way to go? So these are 2 different questions. So one, yes, we work with women who have endometriosis. It's a very common diagnosis for women with infertility. At age 49, you would need to use donor eggs, regardless of if you had endometriosis. The only caveat would be if you had frozen your own eggs previously. So a lot of women who are over age 44 or 45 do need to use donor eggs due to diminished egg numbers and quality. Do you recommend PGTA testing for women in their late 40s? Yes, I recommend PGTA testing for women over the age of 35. There was a large randomized control trial that looked at PGTA versus no PGTA and single embryo transfers. And there was a clear improvement in outcomes in women over the age of 35 who use the technology. If there is tubal blockage, will the only way to conceive be IVF, or are there other alternatives? It really depends on the type of tubal blockage. So if we have proximal occlusion, so blockage at where the fallopian tube is connected to the uterus, sometimes this can be because the tube spasmed during the test, and we could repeat the test and have the radiologist do a procedure where they put a tiny catheter into the tube opening and directly inject a fluid. Sometimes the tubes can be opened up that way. If the tube is blocked more distally and is dilated, called a hydrosalpinx, then oftentimes, especially if both tubes are affected, IVF would be the only means to conceive. So it really depends on the picture of what's going on. Mm-hmm. What is done with any embryos that are transferred, but not transferred, but healthy? So that is up to the individual. We do not discard healthy embryos until the person lets us know what they want to do with them. Some people donate those embryos to research or to other individuals, or sometimes they are simply thawed and discarded. Mm-hmm. Do your chances of pregnancy increase with ovulation induction medications and IUI together? Yes, this is often done as a first initial step for infertility. The ovulation induction medications we use are either Clomid or letrozole. And in women with unexplained infertility, it is recommended that we perform intrauterine insemination as part of that treatment. Mm-hmm. Would a successful IUI be an issue if the partner had had a vasectomy? So a vasectomy, we would not be able to perform an IUI if someone had had a vasectomy, because there would not be any sperm in the sperm sample. In the case of a vasectomy, the choices are to either have a vasectomy reversal, which is a surgery, or to do an IVF cycle with a testicular biopsy to obtain sperm. Okay, this is our last question here. How long can embryos be stored for potential later transfers after a first successful cycle? So embryos can be stored for long periods of time, for 10 years or more. So, we continue to store them until you are done and won't wish us to discard your embryos at that time. But yes, they can be used for subsequent pregnancies years later. Okay, well, this concludes our webinar. Thank you for joining. And again, if you'd like more information, please look at our website at SCRC. Thank you.